just think things that would be useful for both of us as providers to just keep in the back of our minds, but mostly tips for family systems and other care partners of those who love someone living with psychosis or another mental health condition. So, hoping today to talk a little bit about the role that family systems and care partners play in emergency and crisis situations, and then talking about what providers and especially family systems can do before a crisis or emergency, during, and then following. So, that is our goal for today. So, symptoms relapse, as all of us know, are common with psychosis or mental health diagnoses, though unfortunate, but something to be expected. They're stressful and upsetting, obviously, for the individual, but I think bearing in mind how distressing they can be for the people that love that individual who is going through the crisis or emergency situation. And then remembering that family systems are key during this process. Not only are they impacted by the individual living with psychosis and the crisis situation, but they can also impact that situation. Oftentimes, something as what seemingly simple as a communication pitfall, or other disagreements within the home or tensions within the home lead to higher degrees of stress. And this can have negative impact on the entire family system, not just the individual living with the mental health condition. But for an individual living with a mental health condition, especially psychosis, these kinds of situations where there's that increase in stress and tension can lead to an increase in symptoms. And this increase in symptoms or return of symptoms can ultimately lead to crisis, emergency, hospitalization, intersection or interface with criminal justice system. And so being as prepared as possible in advance to try to avoid these situations is the goal that we'll be talking about today. So as providers, things to bear in mind are avoiding times of crisis or emergency situations being the first or the only time that we're really engaging with these family systems. And as you'll see as we go through today's talk, the integral role that family systems can play in preparing for or preventing these crisis situations. It reminds us how key it is for us as providers, especially mental health providers, to be working with that family system in preparation should these things occur. Our goal is always to really help the individual and that family system return to a more stabilized state after a crisis or emergency situation. And then also letting family systems and care partners know that we as providers are a resource and support for them as well. I think knowing that and knowing that they have the ability to give us a call if they have a concern or a question before things escalate is really an important piece of the puzzle in preventing some of these crises. So when I think about it, as I mentioned, like the phases, I think about, things that can be done ahead of time to be planful, things that can be done during the emergency once symptoms or crisis or an emergency has started, and then things that can be done following a crisis situation. So prevention is really key. Avoiding unknown stressors, recognizing symptoms early, knowing who to call and when to make that phone call. We'll go into detail about all of these things, but those I think are like the trifecta for crisis prevention. And then being prepared really can help everyone, not just the individual, but the people that love and support that individual to feel better able to respond because they feel like they have a plan. They know what the steps are, and that can really lead to decreased anxiety and then feelings of empowerment that they know how to respond effectively and quickly in these kinds of situations. So being proactive and being prepared. So it's one thing for families and other support persons to know is being proactive. For example, calling ahead at an agency as soon as you're noting a concern, or if you have a question that something might be of concern. So calling for this guidance with a provider as early as possible, as soon as these signs are observed, instead of waiting for something to escalate. And so not waiting for it to cross that threshold to where it's become problematic. Calling earlier in the day might seem like something that's simple, but a lot of times family systems want to sort of wait and watch, which may be okay, and helping them to understand where that threshold falls about waiting to watch. But if there is something that we know has, historically has presented, an individual has presented, and this seems to be a sign where they might continue to escalate, calling earlier in the day so that they might be able to be seen for a same day appointment isn't something that families may readily think about. And they also may not want to be a bother to the agency. So reinforcing how important it is to call as early as possible. Being prepared. So knowing the numbers to call within your local agency or county, who to call, when to call, what are the emergency services that are available in your local area? Is there a crisis stabilization unit or a crisis team at the agency that can be dispatched out? Understanding the thresholds. And I think that this is a discussion that is so important to have with individuals and their family system. Understanding when is something urgent enough that I need to call 911 or 988, and which one of those do I call? Versus when do I call an emergency line at the agency or the crisis unit at the agency, or when do I reach out to their primary provider, or when do I monitor the situation? And this is going to be different for every person, for every individual. And so having an idea and having these discussions proactively as early as possible with the family system included can really help to avoid, crisis and emergency situations, at least before they escalate. Know as much about the history of the individual, with their psychiatric history, and also what's happening in the current moment. What was the event or the thing that really bothered them that seemed to kind of escalate some of their anxiety or their symptoms. What are some of the things that they're saying? And we'll break that down further. And then having plans in place. So both a relapse prevention plan and a crisis intervention plan, should those things be needed at any point in time. So relapse prevention plan is a proactive strategy. So it's designed to really anticipate any stressors and ways to manage them. It's also a way to learn what an individual's early warning signs are that they might be becoming distressed, and that this distress could lead to symptom relapse. We also want to include multiple partners when developing a relapse prevention plan. So it would be the individual and the provider, but also importantly, the family system. So those individuals who have really been identified as being key supporters, those who are available and willing to help intervene. When you're thinking about what to include in a structured relapse prevention plan, I would always recommend, when you're doing this with an individual, to include the identified family or care partners in both their creation and the agreeing to or the signing off process, so that everybody knows what's expected of them and what the plan is. Gather as much information as you can about the primary mental health provider, and then have a secondary or backup number that you can call at that agency. Part of the plan that you can keep, on, I think it's great to have something like this available in the notes document in your cell phone. You can have a written document, whatever works best for people, but noting the agency specific. So what are their hours of operation? Do they have a crisis stabilization unit or an emergency number? What are those emergency numbers? Who do you call on nights and weekends if there isn't, anybody available at that agency, or they don't have a crisis unit? And what do you do if something doesn't warrant a call to 911 or 988, but it's something that you feel can't just be monitored at home? And so what does the agency recommend for your local county or your local area? Also included in a relapse prevention plan, so that everybody's on the same page, is understanding what leads to increased stress for an individual, because this looks different for everybody. What are the people, the places, the emotions, the situations that can really lead them to increased feelings of distress? Early warning signs of distress or return or worsening of symptoms. So what are those emotional or behavioral changes that you've seen in the past that kind of indicate a person's feeling a little bit more difficult, a little bit more vulnerable, and they're having difficulty regulating some of their emotions? What are things that have worked in the past to kind of calm someone or calm a situation down? These are those healthy, effective coping strategies that we want to make sure family systems are aware of, both so they can support the individual in those coping strategies and they can assist them in utilizing these strategies. You know, coping skills, I think, are great, but when done in isolation and you're in an environment with other people that don't know what to expect or how to assist, they're not as effective as they could be. Knowing the support, so the names and the contact information for those people who have agreed to be part of this support network should an individual start to feel distressed, so that, you know, you have as many people as involved as possible to be involved and to be listed as part of this plan. And then, of course, this is an ongoing, continuous process. So just trying to keep routines consistent, engaging in daily wellness, and then having a check-in system about some of those things. One great way to be proactive is a psychiatric advance directive. You know, should an emergency situation occur where an individual has to be hospitalized, and at that time, they're determined to be unable to make decisions that are in their best interest. Um, so that would be an option for an individual to do. They're also called advanced directives for mental health treatment, or in the formal legal document is called the State of Ohio Declaration for Mental Health Treatment. And they can be legally binding documents that providers are must follow if they have copies of those documents. But it really empowers an individual to identify somebody known as a proxy that they really trust to act on their behalf should that time occur that they've been deemed, you know, unable to make decisions for themselves. This is a temporary, it's not intended to be permanent. And it really helps an individual to say up front, this is the hospital I prefer. These are the medications I don't like. I'm not comfortable with ECT. This is who I would like to care for my children while I'm away. All of those kinds of things. And having something like this in advance not only makes the individual feel more secure that they've laid out their wishes and that they'll be followed, but it also helps decrease the anxiety of the people around them that are trying to, you know, follow those wishes. So when they have the plan, especially if it's a legal document, a binding document, it can be really, really helpful. If an individual has both a psychiatric advance directive and a durable power of attorney for healthcare, the advance directive will always be the controlling document related to mental health care. So I think that that's important to realize, and that it's really important that the proxy has a copy of this document, but also local hospitals, provider agencies, other healthcare providers, if the person resides at a residential facility, if there's been engagement with law enforcement in the past. All of those are really, really great ways to ensure that an individual has their wishes known and followed to the best of the ability of that proxy and those providers. So that legal document is available. It's listed here on this slide that you can access and provide to people. So during a crisis, it's a crisis intervention plan is slightly different because, you know, we've now surpassed the ability to prevent a crisis or an emergency from occurring. So now we are reacting to whatever that event is. It's an immediate response to a high-risk situation where there's potential that an individual could be endangering self or others. You know, the relapse of symptoms has occurred, the individual is experiencing intense distress, and there is a risk of harm. So the primary goal with crisis intervention is to ensure safety as soon as possible and as quickly as possible. When you're thinking about a structured crisis intervention plan, including de-escalation strategies that immediately reduce distress. So what has worked for that individual in the past to bring them down? Preferences about where to seek care and what type of care, something that you would need to know in that immediate sense so that you can convey that information to first responders. Removing that person from a distressful situation or away from people that are contributing to the distress. Making sure that their whole care network is coordinated so that the family system, providers, emergency systems, law enforcement potentially are all involved in acting as one unit. And then I want to talk a little bit about 911 versus 988 and how important it is to know the difference. And then also making sure that families know what a CIT trained officer is. So just very briefly, there's this wonderful document. The link is at the bottom here. It's also in the resources. That is a printable little handout that you can provide to people that helps them understand when to call 911 versus 988. So 911 is when it's an emergency. So there's a life-threatening situation happening where it's a medical emergency. There's an imminent threat to safety, inability to care for self, serious criminal concern, versus 988, where it's a crisis. So it's not necessarily life-threatening in the immediate sense, but it does require some kind of intervention or addressing the issue. So this may be something where they've overused substances, but they don't have severe intoxication or they have an overdose. They're thinking about hurting themselves or others and maybe are even starting a plan, but they're not actively engaging and they don't have access to a weapon. They don't have a weapon in hand, things like that. So 911 versus 988. But I think that this is a wonderful little handout to have available for folks. And when you're talking with family systems about crisis intervention teams, these are teams that include law enforcement patrol officers, so CIT trained officers. They have training in communicating, assessing, and also resolving mental health related crises. They go through, I believe it's 40 hours of additional training. They have individuals from the National Alliance on Mental Illness come in and talk about their experience during mental health crises with a loved one. And they have these opportunities to go out on mental health emergency calls. And so it's a wonderful, all 88 counties have CIT trained officers. That doesn't mean that all dispatchers necessarily know what a CIT officer is, although they're working on that. And it doesn't mean that there's a CIT trained officer available on every shift, but all counties do have a CIT officer. So when calling, I think one of the most important thing to tell family members is that when it's a mental health emergency, telling the dispatcher, if you called 911, that you're requesting an officer with specialized mental health training. Or that it knows how to address mental health emergencies, and that will cue them in if that it's a CIT officer being requested. So the goals of CIT officers are really to improve outcomes, divert from the criminal justice system whenever possible, and really only utilizing law enforcement as first responders when there is that immediate threat to safety or a serious criminal concern. And so that's where they're promoting the use of 988 whenever possible, but never being afraid or when in doubt, feeling like you can call 911. Another really important thing, tips for families that I would encourage you to share is letting the dispatcher or the person answering that 988 call know if the person is a current threat to self, others, or property, if they have access to a weapon or currently have a weapon. The person, the dispatcher needs to know so that they can relate it to the first responders if there's a history of violence or aggression, history of self-harm, if they have a mental health diagnosis and whatever information about that the family or those around them can provide. If there are certain things that really are triggering to an individual, places, people, or things that, alternatively that can really be calming for that person. And if substance use is involved in the current situation that is leading to the call. So, those first few about current threat, access to weapon, history of violence, history of self-harm, and mental health diagnoses, those first 5 are extremely important to convey to the dispatcher when calling 911 or to the person answering the line if calling 988. Encouraging families, as difficult as it is, but to try to remain as calm as possible, convey that information to the person answering your call for help. Remembering that these first responders are trained to manage crises and ensure safety, and so that they feel confident and comfortable enough to take a step back after they provide this information. Reminding, the dispatcher has been told on the phone, but when those first responders show up, making sure that they know that this is a mental health crisis or emergency, and then conveying any information, and then taking a step back and leaving it up to the professionals. And then, being prepared to possibly witness some really upsetting scenes. For example, if the individual is taken into police custody. So, like we said, if in doubt, always err on the side of caution. So, if there's any potential safety issue, situation must be addressed immediately. Feeling free to call 911 or 988, more than likely 911 in that circumstance. So, following a crisis or an emergency situation, family really need to update treatment providers as soon as possible as to what's happening, and then start preparing for the individual to return home if they're potentially hospitalized for a day, several days. And this is where we as providers can step in, reaching out to them while the person is hospitalized or away from the home to prepare them for the return to home from the individual. How are they feeling about that situation? What reservations or concerns do they have? Give them necessary resources, help them think through what might be beneficial for that person when they're coming home, and really checking in on them as individuals and how they're coping to make sure that they feel as though they are ready to handle the individual coming home. Encouraging them to reach out for support, like through organizations such as NAMI, to ensure that they're taking care of themselves and their own mental well-being. And then taking the time to process the crisis or emergency with the individual and the family system. So once somebody is through this crisis or post-hospitalization, normalize symptom relapse, validate those concerns, talk about the circumstances and that led up to this event, because this allows us, it's a really a learning opportunity so that we can ensure that those same set of circumstances are avoided in the future. The family system and the individual are likely feeling pretty down, pretty discouraged that there was this setback, but reminding them that this is, again, providing us with additional information so that we can be better prepared should something like this happen in the future, or so we can learn to avoid this occurring in the future. And also, what are some of the things that may have occurred during that time that we may not want to do again or that we may want to implement next time that might minimize the length of the crisis or the severity or the impact that it has should it occur again in the future. And talking about, okay, what went well during this process of, these phases of the crisis or emergency, and what could have been done differently. What do they wish would have been done differently? Because all of these things can be included in the relapse prevention plan, and in talks with their whole network around them. So I wanted to make sure to include some resources. So there is the 911 versus 988 document. Also, that CIT and calling for emergencies is just a nice two-sided document that talks a little bit about what are CIT officers and, what do you say, when you call to request a CIT officer be dispatched. And also on the other side, it talks about what are some of those things that we said are really important to make sure that the dispatcher knows before officers enter or first responders enter into a situation. And then just a couple other really helpful resources. And so that is all I had for today. And just a reminder of our freeze lecture that's coming up with Dr. Nev Jones. So happy to take any questions, or if anybody has anything that you want to share, would love to hear it.